Sure. So it's my pleasure to introduce Professor Alfouly, lecturer in endemic medicine at Helwan University, and also he's a fellow of gastroenterology of the gastroenterology department at Essen University, Germany. So welcome to join us, Professor Alfouly.
Okay, so we have a male patient today, 56 years old, who was a living donor liver transplant patient. That he got the liver 5 years ago. His primary hepatopathy was cryptogenic liver cirrhosis with suspicion of primary sclerosing cholangitis, but the explant pathology was not decisive for this. He is compliant to immunosuppressive medications such as cyclosporin and MMF. After the liver transplant, by 4 years, he had elevated bilirubin and cholestatic parameter. MRCP showed post-liver transplant anastomotic stricture. The operative biliary anastomosis that was done was 2x1 stentless duct-to-duct right liver lobe graft. Despite previous 3 ERCPs and balloon dilation and stenting of the anastomotic stricture, his cholestatic parameter is still not normalized. Liver biopsy revealed no signs of acute or chronic rejection and no evidence of recurrence of his primary hepatopathy. Today, we're going to do a new ERP with direct spyglass cholangioscopy, balloon dilation, and plastic stents insertion. Professor Alfouly will talk to us about our mission today.
First of all, do you hear me?
Perfect, Professor.
Okay. First of all, I'm very glad and honored to be in this session under your moderation, Professor Fauzi.
Thank you.
And I would like to thank ROYEA and my brother, Dr. Mustafa, for this tremendous preparation for this eminent meeting from different spots all over the world. Also, I have to mention the people in the backstage, like Dr. Nuran, Dr. Amira, and Dr. Muhammad Abu Nasr, Dr. Muhammad Abdul Wahab, and Dr. Muhammad Saad. And I have today my colleagues, Salma and Hana, and the anesthesia team, Dr. Karim and Dr. Film ERCP, hand in hand with the spyglass cholangioscopy by Boston Scientific. Our task today is to assess the intrahepatic biliary system of this transplanted patient with living donor liver transplantation. Unfortunately, he had a history not clear before transplantation of primary sclerosing cholangitis, and he had anastomotic stricture post-transplantation with previous balloon dilatation and stenting. And despite of this, still the patient has some elevation in his cholestatic parameter. So our task today is to examine the native part of the biliary system of the recipient and the anastomotic site, whether there is anastomotic stricture or non-anastomotic biliary lesion, and also the intrahepatic portion in order to see what is the cause behind this elevation of the cholestatic parameters, especially that the liver biopsy was not still inconclusive. We started our examination. If we look to the fluoroscopic picture under the fluoroscopic image, please.
Could you show the fluoro, please?
Yes.
Yeah. Perfect.
If we inject contrast media, now I am standing just above or proximal to the anastomotic stricture. We will inject now contrast media.
Image bigger, please.
Yes, as we see, there is intrahepatic branches of the graft, and below the spyglass cholangioscopy and the fluoroscopic image, there is the native or the recipient bile duct. So I'm actually standing just above the anastomotic stricture. If we shift to the cholangioscopic image.
So it's a long stricture, right, Professor?
Yes, yes. It's a long stricture. It's like 1.5 or 2 centimeters in length. Now, if we display the cholangioscopic image.
Very nice image.
Inject, yeah, you see it clearly. We could irrigate a little bit water. As we see, there is a lot of stones seen inside the biliary system.
Yes,
but if we look here to the mucosa of the biliary tree, could you irrigate a little bit, Salma? Yes. It's look a little bit healthy. I couldn't mention that there is recurrence of the PSC for this patient, or there is some sort of autoimmune cholangitis. But here at the right side with the spyglass, we could see like 2 stones, and they are just above the anastomotic site. If we go a little bit back, you see these stones together with the irrigation. Of course, Salma is helping me very nicely, hand in hand in this examination, to examine these stones just above the stricture. For me, this is a good news that he has not the cause of the elevation of the cholestatic parameters are not due to recurrence of the autoimmune disease, but it seems to be bile stone or bile cast disease post-transplantation, and this part of our differential diagnosis and our task today. If we go a little bit further back, I need to examine the anastomotic stricture, so I will withdraw the spyglass conjoscopy very gently and do a little bit some irrigation. If we looked here to the picture of the fluoroscope, because this is our landmark or guide for the level of our spyglass tip. You see we are now just within or below the anastomotic.
الصورة يعني الصوت السيتنج.
Yes.
Okay. Yes. So,
هو سامعني دلوقتي ولا لا؟
So I am pulling back the scope. Would you irrigate a little bit?
سامعني دلوقتي؟ لا دلوقتي حالا سامعني؟
So now we have a technical problem. We have the sound from both rooms. Maybe we could cut off the sound from Professor Altonberry room and just leave us with the sound from Professor Alfouly room. Otherwise, it's going to be a little bit confusing. So we are following you, Professor Alfouly.
Until you finish, and then we will go to Tumbari after that.
Yes, perfect. Thank you.
Okay, we continue with Amr.
Okay, great. So I will continue my examination with you. Now I am in the native or the recipient part of the CBD. If you irrigate a little bit, Salma, for the biliary system, just to examine the recipient part of the CBD. I'm pulling back a little bit. It's long stricture line, anastomotic line, post-transplantation. Of course, this is a benign stricture, as we know, which is full of mud and pus, as shown here now with the spyglass. Now I am back down in native CBD below this cast. And if we look here to the mucosa of the recipient side, it's totally healthy. Below this is just traumatic. Could you irrigate a little bit, Salma?
Oh.
Yeah. So we could see here a lot of mud and sludge debris of the biliary system.
Professor Alfouly, very nice images. The images are very nice.
So this is, yes, please.
Yes, the images are very clear. And do you give antibiotics when you perform cholangioscopy in these patients?
Yes, this is an important point and crucial in those patients who had liver transplantation, that we give those patients prophylactic antibiotic before our examination as part of the Lyme protocol for those immunocompromised patients to avoid post-ERCP cholangitis with extended beta-lactamase antibiotics.
Okay.
So this is very important. So as we see now, this is seems to be bile cast syndrome or biliary stones above the anastomotic stricture. There is no recurrence of the PSC from the aspect of the biliary system. So now we are confident for the reason. That's why he had this elevated cholestatic parameters. So my second step, I would like to prefer to do balloon dilatation. So we'll go out with a spyglass colonoscopy out of the biliary system. As
So
we see,
Professor Alfouly, what's your diagnosis again?
this is a case of living donor liver transplantation with post-transplant anastomotic stricture, and there is a bile duct stones above the anastomotic line, which could be the cause of the elevated cholestatic parameters after previous dilatation. So we need to evacuate all these stones from the biliary system in order to improve the cholestatic parameters. Our aim is to exclude other causes like recurrence of PSC or association of some infectious causes of biliary ducts post-transplantation like CMV, cholangitis, or a fungal infection. So I don't see any ulceration during my examination, and the picture is clear by the spyglass that this is anastomotic stricture with bile cast above the anastomotic line.
So this case shows beautifully the advantage of cholangioscopy in this case. When Professor Alfouly performed cholangioscopy, he showed very clearly that there were stones in the biliary tree, and the presence of the stones were not clear on the cholangiographic images. So sometimes you see a stricture on the cholangiographic images, and you think this is just a stricture, and you put the cholangioscope, and you see under endoscopy that there are also stones. So this is very nice demonstration.
Yeah, this is one of, I agree with you, because the spyglass cholangioscopy, one of its advantages in the post-transplant setting, that it could also assess the type of the stricture, whether it's very tight or severe, or it's mild. And this could predict in some studies the outcome after repeated balloon dilatation and stenting in the future.
Yeah. So let me check if you agree with me. If your diagnosis is CAST syndrome or PSC, you would just dilate. You would not put stents, because usually stents are not good for PSC or for CAST syndrome. Stents are okay for ischemic strictures or inflammatory strictures, but PSC and CAST syndrome are not good indications for stents, just balloon dilatation. Do we agree, Dr.
Yes, I totally agree with you, because we have to relieve the obstruction and evacuate the biliary system in order to avoid this. And also what's important, that those patients have to receive medical treatment in the form of orthodeoxycholic acid in order to prevent this in the future. I know that this is not totally preventable, but at least this is what's in our hand. I don't know if you have any other suggestions, Professor Fauzi.
Not at all. I think you're correct. Just ursodeoxycholic acid, and that's it, and hope for the best. Very difficult cases. So when we have CAST syndrome or PSC, this is very difficult. In the setting of hepatic transplant, it's also advisable to perform ultrasound with Doppler to check for hepatic artery. Sometimes the patient develops thrombosis of the hepatic artery, and that's the cause of the strictures of the biliary tree.
Yeah, this is one of the important causes, the ischemic type biliary lesions post-transplantation, in order to differentiate it from the anastomotic strictures. But maybe we are lucky because we have the living donor program here in Egypt. This is more common with the cadaveric transplantation. So now, as you see now in the fluoroscopic image, my markers of the balloon is above and below the anastomotic line. Could you push a little bit the wire inside? And now we will start the dilatation session gradually with Salma. Yeah.
What's the diameter of the balloon?
In this patient, I use 8mm balloon screen, 8mm balloon for the several sessions, and I could dilate it gradually in the consequent examination from 8 to 9 and 10, depending on the caliber of the CBD. Would you dilate, Salma? So we will start the balloon dilatation of this anastomotic structure. See, we don't see the contrast. We see just a little bit air inside the piliary system, but still we don't see the dye. Yes?
As you perform the dilatation, we see some stones coming out from the ampulla, right?
Yes. Yes, as we see the endoscopic aspect, you could see a lot of mud and sludge coming out. I am happy with this results for this patient. I mean, like bile cast disease or syndrome will be much better than having recurrent PSC for the new graft. So the solution here will be like just dilatation, medical treatment, and maybe you will need every now and then to do ERCP to evacuate the biliary system from recurrent bile casts.
There is an interesting question from Dr. Al-Musa, Abdullah Al-Musa. He asks, if you have a stricture and proximal to it stones, just like this case, it means you can be sure that the nature of the stricture is benign. There is no malignancy.
Screen. Yeah, now we will see the contrast in the fluoroscopic image, and the balloon, 8mm balloon, is inflated nicely. There is no wasting, so now it's 8mm. We will extend 10mm to be fully inflated, and we will keep this balloon inflated for like 30 to 60 seconds. After this, we will try to evacuate the biliary system using extraction catheter to remove the casts, the intrahepatic casts of the stone from above the stricture.
Okay, so just to answer Professor Dr. Al-Musa question, I think yes, if you have stones associated with the stricture, combined strictures, probably this is benign, but it's not sure, right? So we must always keep a high suspicion for malignant stricture, and if you have some doubt of it, you should try to obtain some specimen under cytology or even biopsy. So the answer is yes, probably is benign, but you cannot be 100% sure. So go ahead, please, Professor Alfouly.
Excuse me?
No, please go ahead. I was just answering some questions for the audience.
I totally agree with you, Professor Fauzi. Yeah, this is, of course, a benign nature of the post-transplant anesthetic stricture. So there is no any suspected features of malignancy. There is no papilliform vessels. For me, and my experience from our center in Germany, that the previous or chaotic vessels is very pathognomonic for malignancy in biliary strictures.
So Dr. Amr, so your plan after that
سامعين
to
ولا
put
لا؟
a stent and to finish your procedure by stent. I'm correct?
Yeah. Thank you. I will evacuate a little bit some mud using the extraction balloon, and then I will put later on a biliary stent.